Welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. This webinar is titled Lung Cancer and Robotic Surgery, and our presenting provider is thoracic surgeon Melanie Edwards. Dr. Edwards sees patients in Ann Arbor. Welcome, Dr. Edwards.
Thank you for that kind introduction, and thank you for the opportunity to present today. I'm happy to be here to just share a little bit of information about lung cancer and robotic surgery. This is going to be chock full of information, so I'm going to dive right in. And if there are any questions, there will be a little, hopefully, time for some Q&A after. So as we look at why is this an important topic to discuss, when we think about lung cancer, we're going to talk somewhat about the treatment, but really there are a few key things. One is that early detection is really the key, and even prevention, and we'll talk a little bit about that. We'll talk about some of the treatment advances and what information is going to be most useful for you if this is something you are dealing with or maybe hoping to avoid dealing with. So this is just for anyone who may be interested in the topic or has a loved one who is going through this or just has questions in general. So we're going to cover a little bit about lung cancer in general. We're going to talk about what are some of the risk factors, how do we even find it, what are some of the concerning symptoms, and then we'll talk about the treatment option, focusing today on surgery and what to expect through that experience. And so lung cancer happens in the lungs. So what are the lungs? The lungs, we've got two of them, a right one and a left one, and they're essential for the body. The lungs and the heart work together as one of the kind of more critical organs that keeps us going for anything that we need to do, all our activities. The lungs are working while we sleep. And we generally have two, like I said, a right lung and a left lung, and then the lung is divided into different sections. This is just a view of the right lung showing the lobes. On the right, you have three lobes, an upper, a middle, and a lower, and then on the left, you've got two, an upper and a lower. On the left lung's a little bit smaller because the heart pushes over and encroaches a little bit on its territory. And so here we can see that surgery, and we'll talk about that a little bit more later, can be limited depending on where a nodule is. Sometimes we can just take out smaller portions of smaller portions of the lung, leaving more healthy tissue behind. And sometimes that's not always feasible. So lung cancer is an abnormal growth of tissue in the lung. These abnormal cells are distinct or different in that they continue to grow and they have the risk of spreading to different organs in the body. But the good news is, and there will be some good news today, is that, let me go back. Sorry, things are a little clicky. The good news is that most of the nodules that are found on a scan are not cancer. Lung nodules can be concerning because we will pay attention to them because of the risk of cancer, but the great majority, especially in this part of the country, can be caused by old infection or burnt out inflammation. And so there's usually a journey with further testing. So who's at risk for lung cancer? There are, almost anyone could be at risk potentially. We'll talk a little bit about that, but there are certain factors that make one person a little bit more risk than someone else. And we probably all know that smoking is a leading risk factor for lung cancer. It is the biggest one. Most lung cancers are related to smoking, probably over, I'd say probably at least 80% or so. So that's a big, big proportion. And as time goes by, that risk increases, especially if individuals continue to smoke. Once you quit smoking, the risk goes down, but it never goes back to zero, and it's always going to be higher than somebody who didn't smoke, assuming you smoked a specific amount. Secondhand smoke matters too. Um, the risk is less than those who have been smokers themselves, but just that exposure over time can make a difference, especially if it's over a long period of time. Radon gas exposure. This is a big risk for non-smokers, especially. Radon is colorless, it's invisible, and it is in many, many homes. And so this is something that it is very important to test for. And then do mitigation. So when we talk about prevention, this is one that anyone should look into, especially if they're not a smoker. And then things in the environment. Asbestos is a big toxin. Fortunately, asbestos isn't as common anymore, but silica dust, there are a lot of chemicals that can also increase the risk. We know that air pollution matters in areas that have high concentrations of air pollution. There can be definitely higher risks of cancer. And then family health and health history. And so if a what we call first degree relative, so somebody who is directly related to you by blood, either a parent or a sibling, that will also increase your risk. If you had radiation to the chest at any point, some people have had radiation in the past for other cancers, and so that can create a risk. And then there's chronic lung disease, emphysema, and a type of lung disease called pulmonary fibrosis. Definitely are known risk factors. And I mentioned a little bit about non-smokers when I talked about radon gas. And that's one identifiable cause, but up to 20% of lung cancers we see occurring in never smokers. And so just because someone never smoked doesn't mean that they're not at risk for lung cancer. The risk is lower, but it's still something that we pay attention to, especially if there are symptoms that develop. Those should always be investigated. So when we talk about symptoms, what are we talking about? So a persistent cough, especially if that cough doesn't go away after treatment. Sort of new development in an adult of something like wheezing or asthma, where you never had that condition before, you don't really have risk factors. Shortness of breath that's new, certainly, and chest pain, or if the cough is one that is producing something like blood or anything, that's a definite symptom. But even a persistent cough that doesn't go away should be a reason to see your doctor for additional testing. I mentioned coughing up blood. That's a definite warning symptom. That's something that should not be ignored and that would require medical evaluation. This is something you definitely check in with your primary care doctor about immediately, even if it's small amounts. Hoarseness, some lung cancers can affect the nerves that may lead to hoarseness, and any trouble swallowing, because occasionally, especially if a tumor is larger, it can push on the esophagus, and which is the tube that food goes to get to the stomach, because there's a lot of organs packed into the chest, and they're all kind of nestled together, and so one can affect the other. But a lot of times there are no symptoms, especially with early lung cancer. And that's the ones that we want to find, because those are the ones that are the most likely to be able to be cured with surgery. And unfortunately, the small treatable cancers, people feel fine and they don't have symptoms. And so screening is a very important part of the treatment and diagnosis of lung cancer because then we can pick up the nodules that are too small to cause symptoms. Unfortunately, sometimes by the time we get to symptoms, things are advanced, still able to be treated, but with more that's needed to manage those. So we have screening programs, and I'll talk about screening criteria. Sometimes someone will have a chest CT done for different reasons. Maybe they have pneumonia or bronchitis and they end up with a CT and they find a lung nodule. Maybe they're in a car accident and they have a lung nodule. So there are a lot of other reasons. Sometimes scans of the abdomen can catch the bottom of the lungs, and those can pick up nodules. So we will find what are called incidental, meaning we weren't looking for them, but we happened to find them. And then the evaluation of symptoms. A CT scan is the most common way that we find lung nodules. We will see some on X-ray, but really only the larger ones are big enough to show up on X-ray. And so a CT scan is where we find them, either if it's intentionally done for screening or if it's a scan that's done for some other reason. We talked about incidental findings, but remember that more than 95% of the lung nodules are not cancer. And so it just means that we just need to either watch the nodule or do some other testing to make sure that there's something, either it's benign or if unfortunately it's lung cancer. So I mentioned screening. Screening is done with a CT scan. It's a low dose scan, so it's not as much radiation if you're getting a scan if you go in with symptoms. And this is the key. It's to look for the disease before the symptoms start. And we really want to target this. And so if you are, for example, a non-smoker and you tested your home for radon, it probably won't be valuable to undergo lung cancer screening because your likelihood of finding something is going to be quite low. So who should actually consider screening? So these are going to be patients or people, individuals within a specified age range. We're looking at ages 50 to 80. And this may expand, and these criteria have already expanded a little bit from when they were originally put forward. The screening guidelines have continued to evolve as we understand more about the risk. And so we've actually lowered the age to 50, at which people should start with a yearly low-dose CT. And the people who should start are anyone who has smoked enough in their lifetime that that exposure would put them at risk for lung cancer. And that's been determined now to be what we call 20 pack years. And so that's if you smoked the equivalent of 1 pack per day for a year. So if you smoked a half a pack per day for 40 years, then that would give you your 20 pack year smoking history. So if you smoked a couple cigarettes in high school and you're now 75, you probably wouldn't qualify for lung cancer screening. And it doesn't matter when you quit. If you quit yesterday or if you quit a year ago, then once you meet these two criteria, you then have the conversation. But it's also important that you can undergo the treatment and that you're healthy enough to go through the evaluation. We talked a little bit about early detection, and with that comes the possibility, most likelihood of hopefully better outcomes and being able to undergo less invasive treatment. There are some risks with screening. There are false alarms. Like I said, the great majority of lung nodules are not cancer. And so we have algorithms that will tell us who to then do more invasive testing like a biopsy, who to just watch, and and be able to focus down a little bit more. And so sometimes there is more extra testing that's needed. So once we get through the screening part, say we find a lung nodule, it's been reviewed. Here at Trinity, we have a multidisciplinary review. That means doctors in different specialties get together and we use the guidelines and then tailor them for the patients that we're seeing and make a determination. So surgery is one option, certainly, and it's the primary option for treating early stage lung cancer. We will sometimes use it in cancer that's a little bit more advanced, and sometimes it will be used in those instances, it will be used in combination with other treatments such as chemotherapy or a type of therapy called immunotherapy given with chemotherapy alone as also. So we do the staging to make sure that it is treatable with surgery, that it's contained and it can all be removed. And then we have to make sure that the person with the lung cancer has good enough health to be able to tolerate an operation and still then get back to doing all the things that they are important to them, and that they don't lose quality of life. So what'll happen is preparation. So there's imaging in addition to the CT scan, say that discover the nodule. We will do what's called a PET scan, which is a scan that will give us a little bit more information about the risk of cancer in a nodule and if there's been any spread. We will sometimes scan the brain or do other testing. Breathing tests are important because we have to know how much lung capacity you have before we're able to say, okay, yes, it is safe to take out this X amount of lung tissue based on where a specific cancer is needed. Oftentimes, increasingly, we'll do biopsies to prove that there is a lung cancer. We don't always have to. Sometimes we can take out small amounts of lung tissue and then while the person is in surgery, figure out if it's cancer and then take more if we need to be more complete about how much we've taken out. But there are other ways to biopsy this. I'll talk about that in a minute. And then we do education both with the surgeon and also the nursing team to go over the expectations and preparation. One of the ways that we can biopsy nodules is with what's called robotic bronchoscopy. The platform or the brand, so to speak, that we use here is called Ion. It is a small catheter that we can drive all the way out to the edge of the lung almost, and then take some samples. We found that it's safer than some of the ways that we used to do biopsies. And in the future, we're hoping to maybe even start treating some small cancers with this technology. So more to come there. With respect to surgery, lung cancer is just one part of a breadth of thoracic surgery and robotic surgery that we're able to offer. And it's been I think, transformation in thoracic surgery over the last 20 years with increasing use of robotic surgery because we found it to be beneficial for patients in terms of recovery and what we're able to do. So specifically for lung cancer surgery, the robotic surgery is certainly one, and it's probably right now a little bit more than half of the lung surgery for lung cancer in the United States is done with a robotic platform. Video-assisted surgery was the first type of what we call minimally invasive surgery that we had done. Video-assisted surgery is also done with small incisions, but it is a little bit older technology, and so there maybe is not as much precision. And then traditional open surgery involves making an incision and spreading the ribs and then actually getting your hands in the chest to do the operation. And so that's the incision part. And then when we think about lung surgery, we think about it in two ways. How are we going to get in? And then what are we going to do when we're there? And what we do when we're there is how much lung are we removing? And that depends on the tumor size and where it is located, as well as the stage of the tumor also. Our goal is to take out all the cancer. We want to take out all the cancer we can see and make sure that we cover all the cancer that we potentially might not see that may be invisible but could show up on a microscope once that lung is in pathology. And so we can start with taking just a small portion or a wedge for the really small nodules. The most common operation done is a lobectomy because sometimes nodules are too deep to reach with a wedge. If we have to, we'll take out a whole lung, but we try to avoid this. It's a pretty major operation. So increasingly, the first two options, either wedge or segment, or maybe a lobectomy, are what we end up doing for surgery. So this is just an example of what things might look like with a wedge resection. Here we've tagged the nodule location, and you can see the lungs here are pink, but there are these little black spots either from smoking. We've injected some dye so we can find the area where the nodule is and see it lighting up. There's additional technology that we can use to find some of the small nodules that we can't see. And then we have these robotic staplers. These staplers are pretty nifty. They've got multiple rows of very tiny titanium staples. You can see a staple right there, actually. And we clamp, and then it'll fire and cut in between, and that's how we actually remove the lung tissue. So you'll see the stapler firing there. And then you can see a staple line up there. There's another one down there. So that is what we talk about when we're looking at what's called a wedge resection. And then we just kind of march along until you get all the way around the nodule to make sure you've gotten what's called a good margin. Um, Beyond just what we call wedge resections and segment resections, we can do some pretty cool things with the robotic platform. When we're looking inside, the surgeon has what's called 3D vision, and the instruments have wrists to them. So we can do, I'm going to fast forward this here. You can see a bronchoscope. We're looking to find a nodule that is inside the airway. So you can't really see from the outside where it is. And then we're going to cut here to open that up. This happened to be a type of tumor called a carcinoid tumor. They're not as aggressive, so we don't have to get really super large margins when we take that out. So you can see here, we're just cutting that airway to expose the tumor. And now we've got the airway. This is called the bronchus, this little open end here. That bulb there is the tumor. And now we just use the robotic platform and suture that end together. And once we've sutured that end together, you can see the suturing there. You got that all sealed up. And so so there's a lot of flexibility that you have with a robotic platform, and it allows you to do all this without having to do, say, rib spreading or the typical open incisions. So typically for robotic lobectomy, we actually do 5 small incisions in between the ribs, but we don't have to do one large one, and we don't have to spread the ribs. This is what the arms look like that are going to be attached to the patient, and then there's a console where we have the 3D vision. One of the big advantages is less pain and faster recovery in the short term, and so patients are able to get back to regular activity. I've had patients go back to playing golf and tennis within a few weeks after surgery. And for us, and so those are the benefits to patients. For us, the benefit is that we have 3D vision, we have greater precision. We know that when we look at lung cancer surgery, for example, we're able to get more lymph nodes when we use a robotic platform because of that better precision. So during the operation, we've got the multiple incisions. Typical lung cancer surgery is going to last anywhere from 2 to 4 hours, depending on how much we have to do. And you saw an example there of some of the advanced techniques that we're able to do, and the advanced um, uh, uh, other supporting technology, such as being able to find tumors that we can't feel with what's called fluorescence. And so once the tumor is taken out, we also take out as many lymph nodes as we can. And then after surgery, most people are going to be in the hospital for anywhere from 2 to 4 days, although we're kind of getting we're able to say, if a patient had a wedge resection, usually they go home the next day after surgery, and then the more complex operations, patients will stay in a little bit longer. From the operation, day one, the patient will then go to the recovery area, and they're monitored there to make sure that they're recovering from surgery, that there aren't any immediate problems. And then they go to the regular floor, and we encourage what we call early mobility and encourage patients to get up and move as soon as possible. You think, how are you going to do that after lung surgery? It's so important. Movement allows for faster recovery. It allows you to be upright, expand your lungs better, your tubes drain a little bit better, so you're less likely to have materials retained in the chest, and your recovery both in the short term in terms of the lung expanding, and then long term getting back to regular activity is much improved. The chest tube comes out usually, like I said, day 2 to 3 is average, but it can come out as soon as day 1, and then mostly patients go home the same day the chest tube comes out. And we have, fortunately, an enhanced recovery pathway. So we've got a protocol to optimize and help patients through to ensure people recover as best as possible. A chest tube, we have to mention that we're still using chest tubes. I think every surgeon does. Once we're done with surgery, there's going to be fluid, there's going to be air that can sometimes leak from those staple lines. They're very good, but they're not always 100% sealed. Sometimes there are other areas of the lung that can leak. And so the chest tube stays in until that's all sealed enough to where we won't worry about excess fluid or air building up in the chest. But you can move with chest tubes. And so, like I said, we get patients up and walking the day of surgery, even with the tube in place. And then at home, recovery, I need to get rid of the patient with the recliner because we do encourage people to get up and move and stay active. Most of our family members are going to want to swaddle us with love and care and attention, but it does do us some good to, go fix ourselves a snack or, something light like that, and then slowly work your way back into normal life. And it takes time. The incisions are small, but there is discomfort, and that takes a few weeks to ease off. But usually, by the time patients get to week 3, week 4, they're doing laundry, doing their own housework, and trying to get back into their regular routine. So then, what happens with respect to the cancer after lung cancer surgery? Are patients done? Fortunately, the majority of patients who we diagnose with stage 1 lung cancer up front don't need additional treatment. But sometimes we will find something at the time of surgery that will increase the risk of it coming back. And so then we'll have to do additional testing, genetic testing on the tumor, and confer and meet with medical oncology to determine the next course of treatment. Or if there isn't the need for additional treatment, say it's a early stage, low risk tumor, the margins are all negative, meaning we got it all. The lymph nodes are negative, meaning it didn't spread. Then typically it ends up being a CT scan about every 6 months to monitor things because unfortunately, once someone has a lung cancer, they are at risk for developing another tumor, especially within the first 2 years. Um, I'm going to talk again a little bit about quitting smoking. We talked about tobacco as a risk factor, but even around the time of surgery, it's not too late to quit. And that's sort of the message. It still makes a difference. Even if you haven't been diagnosed with cancer, or you're worried about it, or you have been diagnosed. With respect to the cancer treatment and surgery, it just makes it better, easier, and safer to undergo surgery once you quit smoking. The tissues get more oxygen, things heal better. The lungs are healthier and so they can recover better. There's less risk of pneumonia, less risk of breathing problems, and overall less risk of the cancer coming back and less risk of the remaining lung tissue continuing to deteriorate. And we do have tobacco counselors in our center here that can assist with counseling, and we can certainly assist with any other medications that are needed to help with smoking. So as we wrap up, understand that lung cancer, unfortunately, can be silent. There can be no symptoms, especially in the early stages, but these are the stages where we really want to find things so that we can then use the robotic platform and be able to offer up-to-date treatment. We can find lung cancer early by screening. And we talked about the populations. It's a low dose CT scan once a year to definitely improve survival. We know that screening improves survival and decreases the death rates from lung cancer by 20%, which is about at least what you would see with other cancers such as breast and colon cancer. And we also recommend screening for those. And if unfortunately we find something, especially if it's early stage, we're able to do this with small incisions and minimally invasive techniques to facilitate a faster recovery. But we have a team. There's a team from the time a lung nodule is found. We have both physicians, both in surgery, in pulmonary, in oncology, and we also have nurses, navigators to help with the management, help with the workup, and provide all the support that is needed. So, what next? We've covered a lot of information. It depends on where you are. Certainly, if you're worried about your lung cancer risk, then it's a good conversation to have with your doctor, in addition with your other screenings to see if lung cancer screening is something that would be right for you. And if you meet the criteria, then you can be referred. Pay attention to any symptoms. This is a tough time of year because respiratory symptoms come and go. But if something is persisting beyond the recovery time frame, ask questions. Should I get an X-ray? If the X-ray didn't show something, should I get a CT scan if I'm not feeling better? And then prevention is really the most important thing. We know quitting smoking and avoiding certain exposures if possible, radon and environmental exposures, because really the key is we don't want to have the small incision surgery or the robotic surgery. We want to avoid that. We want to stay healthy. So with that, I thank you for your time. I thank you for your attention. This is an important topic, and I'm glad you're here to hear this, and hopefully we're able to give you some useful information today. We have so many transformations in lung cancer care, too many to talk about, but we're happy to discuss any questions that may show up.
Okay, thank you, Dr. Edwards. So we do have a handful of questions. I will start from the top there, but if you have a question that you haven't entered yet into the Q&A, please do so at any point here. You'll find that feature at the bottom of your Zoom screen. Okay, so the first question is CT screening paid by insurances? That may be a difficult one to answer.
Well, actually, it's so if you meet screening criteria, then actually yes. Because and that was one of the big problems initially was getting CMS. What CMS is the organization that administers Medicare. And so back in 2012, 2013, when the initial recommendations came out from the US Preventative Task Force, then that had to go through CMS to get approval for coverage. And so that's why the criteria are relatively strict in that you meet the criteria, but it should be no different than breast or colon cancer screening.
Okay, excellent. Is screening recommended for a person whose parent died from lung cancer?
So, this is the challenging part is that we know that there are other non-smokers who are higher risk for cancer, but the screening guidelines do not include them. And so that becomes a personal discussion with you and your primary care doctor. And part of the reason for that is we got the guidelines for who to screen based on the known risk and based on research that was done where we took a large number of smokers and looked at their risk and did the scans every year and found out from that study that there was a 20% decreased death rate from cancer with screening. But the problem is those studies did not include people who don't smoke because that's only about 10 to 20% of the individuals with lung cancer. They screened the original NLST trial that did this had over 4,000 patients. And so it takes a lot of it's a little challenging to answer these questions when we have something that doesn't happen as often and we don't have the same clear-cut link between risk and the outcome. So that's a long-winded answer to say it's a discussion with your doctor. There are certain genetic problems like BRCA or Lynch syndrome that run in the family. So if you have a lot of family members, then definitely have that discussion.
Okay. Can bronchioplasty be used for metastatic lung nodules? Also, do nodules have to be above a certain size before it's possible?
Yeah, so metastatic nodules, and I'm assuming this is a metastatic nodule from another type of cancer. And so, yes, we will operate on those. We usually will either do a wedge resection or a segmentectomy, sometimes even a lobectomy, but we have to very carefully select patients when we're operating for what's called stage 4 or metastatic disease, because we want to make sure with surgery that we're getting out all the tumor, even the microscopic tumor that we can't see. And when there's a metastatic disease component, or when that's the situation, there's more likely to be microscopic tumor cells that you can't see. So there are certain guidelines there. We take a lot of factors into effect. How many spots there are? Can we get it all? How long has it been since the first cancer was treated? What are all the options for treating this cancer? So the answer is yes, but we do select those cases carefully.
Okay. Do you know what the survival rate is after surgery?
Yes. So for stage one lung cancer, the 5-year survival rate is going to be are somewhere around 70 to 80%, depending on the specific type of tumor. We know that the risk of a lung cancer coming back after surgery for stage one lung cancer can be anywhere from 20 to 30%. And so that's why it's important. Once the surgery is completed, we're not done. We still have to monitor because even with small nodules where a PET scan, which is the scan that we use to screen for metastatic disease, is crystal clear. We take all the lymph nodes, the margins are wide. Lung cancer is it's not a nice disease. Let's just put it that way. So it will come back in that proportion, unfortunately.
Okay. If you have small nodules in several lobes, robotics remove them all in a biopsy. During the procedure, is the sample tested? Does that make sense?
Yes, so the ion robotic bronchoscopy, I'm assuming that's what we're talking about. So we're not talking about the robotic surgery to take out lung cancer because that's more targeted. We're taking out one nodule, maybe two if they're small, but we're talking about the biopsy procedure. So yes, if there are multiple nodules in different lobes, the ion robotic bronchoscopy, which is going to go through the airway out into the edge of the lung and take little samples can biopsy multiple nodules in the same setting. And that's one of the very nice advantages of this technology. We've had this technology now at Trinity for, I think, almost a year and a half, 2 years, and it's made a very big difference in what we're able to do in terms of diagnosis for patients with lung nodules, where sometimes we just didn't know and we're just like repeating CT scans month after month after month. Um, Whether or not it's tested on site depends. There is a capability, but sometimes it's better just to use all the tissue for the final testing if nothing's going to be done at that same time. So they can, but usually it's better just to take all the samples and then the pathologist can take their time and look at it carefully and figure out what's going on.